Hi everybody. I'm going to spend about the next 10 minutes talking about a subject which I'm passionate about and could take all day on if I was given the opportunity, and that is the evidence base behind the prescribing of drugs to a lactating mother. I believe very strongly that it's only by understanding how the drug passes into breast milk that we can produce evidence-based information for the mother. I'm thinking also about, do we need to manage breastfeeding, and does it help if we're prescribing? How can we use the information to support breastfeeding mothers to feed as they have chosen? And in doing so, understand that breastfeeding is about so much more than just milk. And mainly, ultimately, we need to decide what is the risk of the drug passing to the baby through breast milk and the risk of not breastfeeding. And there are always two sides to every story. I only have 10 minutes. If you want to understand more about the pharmacokinetics, there is a link here to a YouTube video that I did taking about 30 minutes explaining how drugs pass into breast milk. In an ideal world, we want to choose drugs which are licensed for children. So any drug that can be given directly to a child is safe for a breastfeeding mother. A quick example of that, mebendazole for threadworms. Mebendazole stays in the gut, but also we actually give the mother the same dose as we give to a child because it is staying in the gut, not passing into breast milk. We need to use drugs on which we have data, not the newest, most whizzy drug that we have seen a drug rep for or read about. Sometimes the old ones are the best ones. And we need to look at certain pharmacokinetic data. Drugs which have poor bioavailability, which means that they can't be absorbed from milk no matter how much gets in there. So examples of things like gentamicin, insulin, the large molecules that have to be given by injection, and this includes all the biological drugs. We want drugs which are extensively plasma protein bound because that means they stay attached to the albumin in the bloodstream and can't pass into breast milk. And drugs which have a short half-life so that their level has gone up and comes down very quickly. If the half-life is over 24 hours, at the end of 24 hours we may be giving another 100% of the drug, and if the half-life is considerably longer, it can lead to accumulation. And we want drugs which stay in the mother's plasma and don't get as highly into milk. And the relative infant dose, if you remember nothing else, look at specialist sources and look at the relative infant dose. Anything less than 10% is a safer drug. In the first few days after birth, we probably give more drugs than at any other time. But this is the time when there are gaps between the alveolar cells, and any drug that is in the mother's bloodstream passes straight through into milk. So the baby will get considerably more, and things like bioavailability go out of the window. They're going straight through. But at the same time, the actual volume of colostrum being consumed by the baby is small, so the absolute transfer of drugs is small. By the time we've gone for a few days in, the drug can't pass through the gaps because they've now closed up and has to cross the cell membrane. So the baby is in a much safer position. Simple diffusion sounds very simple, but actually there are lots of fat membranes to get through, which actually cause a lot of barrier for the baby. So oral bioavailability includes things like contrast medium in CT and MRI scans. These drugs are not orally bioavailable. They are just contrasts and they don't pass into breast milk, but the standard information is to not breastfeed for 24 hours. Drugs which have high milk plasma ratios concentrate in milk. So alcohol reaches the same level in milk as it does in the mother's bloodstream. and it takes about 2 hours for 1 unit to have cleared the bloodstream. But cannabis has a milk plasma ratio of 8 and it's fat soluble, so if a mother is using cannabis regularly, it will concentrate in the baby's brain. Iodine has a level of 26, so we should avoid anything which has iodine in it, even iodine dressings. And when I talked about fluconazole half-life in a baby less than 6 weeks is 88 hours. So we need to be very, very careful if we're prescribing this to treat thrush in the breast in a young baby. The time to maximum level in breast milk is often quoted, and sometimes mum will try desperately to find time feeds so that the drugs are at their lowest, and this is often particularly around drugs for anxiety and depression. So things like sertraline, they will try their hardest to not feed for a few hours after they've taken it. But actually, once the drug has been in the system for 5 half-lives, generally around about 3 days, it should reach a steady state and timing is absolutely pointless. And mum can just feed and carry on as normal. In the past, many women were told they couldn't breastfeed for 24 hours after a general anaesthetic, but last August I was very privileged to be part of a team who provided these guidelines, and we actually made a small little sticker which we meant to be laminated to be in every theatre in the country. The same guidelines cover midazolam for sedation, but I'm hearing regularly of cases where mums are being told that if they have a sedative for a colonoscopy, that they can't breastfeed for 24 hours. There is no evidence for this. The drug is cleared very quickly. We need to remember that the mum may be at risk of mastitis if she doesn't feed for 24 hours. The baby may refuse a bottle. It may be intolerant of the formula. So we have to go back and think about where is the risk, where is the benefit. We don't have any information on remdesivir, so the SPC will say do not take if you're breastfeeding. But actually, we know that it's poorly absorbed orally, so clinical amounts probably very low. Lack of evidence doesn't mean risk. It just means we don't have evidence. Sometimes it's necessary for a mum to pump and dump temporarily. But dumping makes milk sound valueless, and if a professional uses a throwaway remark, it can be really discouraging to a mum. Let's talk about pump and save. If nothing else, it can be used in the baby's bath. It's really good for skin, and it's incredibly good for treating eczema. Does a mum have a breast pump? If she's been admitted to a surgical ward in an emergency, is there one available for her? Does she have clear instructions on how often to pump to avoid the risk of mastitis, and a clear plan of when she can get back to breastfeeding? It takes determination to maintain a supply. Let's say she's in hospital for 5 days, but if she doesn't pump frequently enough, we may be prescribing antibiotics. Involve the infant feeding coordinator at the hospital if you can, so that there is clear information. I'm not going to have time to go through all of these slides, but these examples, but I'm going to pick out codeine versus dihydrocodeine. Some mothers are rapid metabolizers of codeine, and it concentrates in breast milk, and their babies show this by becoming drowsy. The preferred drug in a breastfeeding mum is dihydrocodeine. Lots of concerns about it being addictive, but then so is codeine. The MHRA have said that codeine should not be prescribed for a breastfeeding mother. There is some discussion at the moment as whether the original research was flawed, but at the moment those are the guidelines. This is the information about midazolam. It was actually used against nitrazepam in newborn babies, so it was passing straight through. NICE guidelines say we shouldn't just use the BNF, we need to use specialist sources, and that actually telling a mum to stop breastfeeding has health consequences for both of them. The MHRA have launched in January this year a consortium whose prime target is to provide adequate evidence-based information for pregnant and breastfeeding women so that they can be involved in decision making. There are thousands of babies born every year who will be exposed in pregnancy, and the same in breastfeeding. I've been very proud to be part of this consortium. Milk doesn't turn off like a tap, and in trying to do no harm, we may cause harm. So in summary, we can use pharmacokinetics, we can use specialist sources, which I'm just going to point you towards. We can help mums with expressing, but actually most drugs are compatible with breastfeeding, or there is an alternative which is. So these are the sort of sources that I would send you to. LacMed is a freely available online source which has all the studies. The first box is actually quite understandable by mums. UK Dialysis has a wonderful set of information, and you can also, as healthcare professionals, call them. Hale's Medications and Mother's Milk probably contains every drug there is going. I've written fact sheets for the Breastfeeding Network and for my own website to try and save you time from having to look them up. Health professionals need to use evidence-based support sources, and we need to be sensitive to the needs of mothers. If I can help, I'm always glad to be emailed, or that you can visit my social media page. Thanks for listening, and I hope that short run through makes sense. Bye.